Move on to our next speaker. Our next speaker is Dr. Prajakta Deshpande, who is a very skillful cataract and refractive surgeon, and she is director of Shri Ramakrishna Netralaya, Thane, Navi Mumbai. Dr. Prajakta, can you start your screen sharing?
Thank you, Dr. Harshul and Dr. Chitra ma'am and team ARC for this wonderful opportunity. I'm just sharing my video. Please hold for a second.
Dr. Prajakta, you need to open the PPT presentation.
Yes, please hold for a second. I'm doing that. Is my video visible?
Yes. Please
Yeah.
go ahead.
So this was a 75-year-old gentleman who had a partially absorbed mature cataract with a thick plaque under the anterior capsule. So I decided to go ahead with SICS. I made a scleral tunnel large enough for the delivery of the nucleus. Stained the capsule with trypan blue. Entered the anterior chamber with a keratome and extended the tunnel. So while doing rexis, I noticed that the capsule was very rough and it was completely stuck to the underlying thick plaque. I wanted to make a large rexis in the first go itself, but the capsule wasn't moving very easily and my rexis became small. The capsule was very much adherent to the underlying plaque. Then I had to make a double rexis. And finally, I could get the required size of the rexis. As you can see, the anterior capsule was very much adherent to the underlying plaque. I tried to remove it with the spatula. Then I tried to dissect it with a needle, but I could not. Finally, I had to cut the plaque with a forceps, with a scissor from all the sides. The plaque got released now. I removed the plaque and then the nucleus was free from all the surrounding structures. And I could easily deliver the nucleus in the anterior chamber. I injected visco above and then below the nucleus. And with a irrigating wet disc, I delivered the nucleus out of the eyeball. As you can see, the nucleus was quite hard and brown. It had a brown tone. Since it was a partially absorbed cataract, I wasn't expecting much of a cortex. So I just visco expressed whatever cortex was there in the bag and placed a 6 mm lens inside the bag. As you can see, the plaque was still adherent to the rexus margin. Initially, I tried to remove it with the eye. It did not come out. Then I just tried to dissect it with a spatula. I could not remove it. Finally, I had to hold it with a forceps in one hand and then dissect with a spatula in the other hand. And then this was a small thing I learned from this case. That is, for removing such type of plaque, you need to use both the hands, and holding and dissection should occur simultaneously. I managed to remove all the plaques. I cleared off the visco from the anterior chamber. Hydrated the tunnel and the side ports and cauterized the conjunctiva. And this was the final result. Thank you for the patient listening.
Thank you very much, Dr. Prajakta. That was a wonderful video, and lot of
Yeah.
discussion to come up.
Thank you, ma'am.
I wanted Dr. Deepak Meghur to have joined in for this case. Is he there, Dr. Deepak? Not
Yeah,
joining?
I'm here. I'm
Yeah,
here.
you're there. See, this incidentally, of course, was not as fibrous, but she did have a lot of difficulty. You know, she had to cut the subcapsular plaque and to remove it, and a lot of extensive dissection was done, which made me wonder whether the zonal integrity could have got compromised. What would your thoughts be in these dense cataract with subcapsular plaque?
Yeah. I think there are two different variants we need to differentiate intraoperatively itself. One, if it's purely fibrotic and there is not much of an underlying plaque here, the best instrument would be either to use the scissors, and vitrector is an ideal option here.
Right.
Using a vitrectomy cutter is an excellent device to use in these fibrotic variants. If you're not able to dissect out the subcapsular plaque. If you're able to dissect out the subcapsular plaque, you dissect it out and then enlarge the rexus. But sometimes if it's the fibrotic band have already gone towards the periphery, it might not be possible for us to dissect out this plaque. Then in this situation, using a vitrector would be a better idea to deal with it.
Oh, okay.
Absolutely.
Yes. That
Also,
was,
I think, also, I think in these cases, if you have to actually cut it and you use a micro scissors rather than this instrument, which is a big blade, then you open it inside, then, you know, it can get a little clumsy. So if you use a micro scissors, which just opens inside, then it is a lot
Use
easier.
a vitreous scissors.
Yeah,
Use
yeah, your retina people use those scissors,
Yes,
the
yes. Use that.
ILM scissors used for ILM. Even
Yeah.
those scissors are quite good, even if you don't have a dedicated micro scissors for this. But
think,
the best part was the way the nucleus came out. I mean, sometimes you think,
Yeah, that's
why
what.
do you struggle with such a hard cataract and, you know, try to phaco it in one
Yeah.
session, the
I felt
your
that
nucleus came out.
Aspasius was amazing.
Yeah, it was very.
Doesn't come out so easily the way she's anyway.
Beautiful.
I think
Can I
this.
add one
have-
point?
I would have done a phaco because this rexus doesn't extend at all. It's a fibrotic rexus, it doesn't extend. So you can actually do a phaco without any problem.
No,
I
but the take-home point from what Dr. Deepak said is ensure that we separate the subcapsular plaque and then only go on to enlarge our rexus,
Absolutely.
because
Absolutely.
you would not go wrong that way. And
I
of
think-
course, use a vitrector.
I think there are two things, what you should do to separate these plaques.
Yeah,
First is the dissector which was being used was a very gross dissector.
yeah,
The dissector which we use to open the incisions of the femto incisions, that can be used to, to open, to create a plane and then enlarge it. And you can use a thin visco dissector also to go underneath it once you have a small one, and then you can enlarge it. Such a large dissector usually doesn't help. Dr. Deepak, do you agree with me? Because you are very much into it.
Yeah, absolutely, sir. I agree with it. I would prefer a flat spatula, like an iris repositor, micro iris repositor. It's very thin, and then you have to create a plane, a cleavage plane. And when blunt dissection, once you create it, then you inject dispersive OVD into it. Then it separates. Then again blunt dissection. That's going to work.
Yeah, and I think that's the most important click. Yeah, absolutely.
The incision opening is a good idea, Rohit.
yes.
Can I add 1 point or 2 points actually? What I feel is the two-hand technique is an excellent thing, and the surgeon has showed that she has got a lot of skill, because you can easily pull away the bag, and if you put a lot of pressure. We do encounter a lot of such cases. Everybody does, I guess, in the cam setting particularly. So sometimes when I have seen that the scissors also does not cut it, or the micro scissors or any scissors doesn't cut it. So I have sometimes cut it with a keratome knife also, which works pretty good.
Yeah. Sometimes it's so fibrotic, you have to put a MVR to get a small, small area of separation, which can then be dealt with the help of scissors.
Yes. Thank you very much, and thanks for all your inputs, and Dr. Deepak too, which was very valuable.